discussion on APRN practices, I have Dr. Michael McNamara with us, and I'll just have him go ahead and introduce himself and talk about where he works.
Good afternoon. My name is Michael McNamara. I'm a physician here at Sanford. Maternal fetal medicine is my subspecialty, and do OB/GYN as well. My practice involves high-risk patients, and the most common type of complications in pregnancies that we see are chronic hypertension and diabetes that affect the maternal condition during the pregnancy.
All right, so today I just wanted to look further into APRN practices and how they can specifically reduce health disparities, and also provide one unique APRN work setting that can address these disparities that we see in South Dakota. So today we just want to look further into your practice and see how that is being done. One way that I've seen in the past is through your outreach. And so I was wondering if you could explain more about your outreach and the population that you serve.
Well, South Dakota is a pretty big state, but there's not a whole lot of people, and the people in South Dakota are usually located in just some few areas of the state. And in some areas of the state, there's a number of areas, Indian reservations, that rely on the IHS service, the Indian Health Service, for their OB, or really for their health care. In those areas, the IHS has very little support from the OB standpoint, unfortunately, and our outreaches allow us to go near these Indian Health Service areas and provide them care that they wouldn't be able to get, with the goal of having healthy moms and healthy babies for their families and their own health.
Very good.
The two outreaches that I participate in, one is an area called Winter, South Dakota, that has a number of reservations, most specifically Rosebud, and also around in Valentine, Nebraska area. A number of those patients, though they have a lot of medical problems, they have very little means to go anywhere other than locally for their health care. These patients are usually 3-4 hours away from being able to come to the big centers, and in order to give them health care, you could ask them to come, but they oftentimes do not have the means to do that. And they have certainly other issues within their families and that they have that are oftentimes higher priorities to them than the healthcare, than their own healthcare and the health of their baby during the pregnancy. The other area that I go to is Rapid City. And Rapid City has a couple different reservations, large reservations, that one that doesn't do healthcare or doesn't do OB, which is Eagle Butte, and then the other one does OB care. It's staffed mostly by midwives, and half the time they'll have an obstetrician that works with them, but most of the time they're on diversion and sending their patients for delivery up to Rapid City, and that would be the Pine Ridge Indian Reservation. So by being in our outreach clinics nearby these reservations, we're able to give them care and hopefully guide their providers in taking care of the patient and their baby, and providing them with a framework to do their care and have healthy moms and healthy babies at the end of the day.
On a weekly basis, how many patients do you see?
In my clinics, which are the outreach clinics and my clinics here in Sioux Falls, I probably see maybe 80 patients in a week.
And then also as your staff, you have APRNs as well.
I do, and they normally don't see my patients primarily. I usually see them myself, but they do follow up on different issues in pregnancies, such as diabetes, which is probably the most important help they can give to me, since the diabetic care is one of the more important things in the pregnancy for the mom's health, but also for the baby as well.
So I was just going to mention that too, is that with the native population, one of the biggest health disparities that we see is diabetes. And I mentioned that previously in my PowerPoint. And these patients are unable to schedule appointments with providers, which can be a huge setback when you're trying to manage a patient with diabetes, especially seeing somebody maybe that has had limited care throughout their pregnancy. So I just wanted you to maybe describe a little bit how the APRNs have developed a diabetic clinic within the MFM practice, and the important role that they have played in addressing these disparities.
With the patients living so far away, it's not easy for them to come in on a weekly basis to review sugars, and oftentimes when we want to adjust insulin or other medications for diabetes, we do it on a weekly basis. It's certainly difficult to come into a facility and drop everything else you're doing in your life to just have your sugars reviewed. But by being able to communicate with them either through the internet or through cellular phones, we're able to review the sugars with the patient on a weekly basis and then make adjustments to their insulin based on what their sugars look like. And oftentimes in these patients, we may not see them in clinic for 3 to 4 weeks, and to let that amount of time pass with abnormal sugars, it's going to be detrimental to both the patient and their baby. So by having our APPs be in contact with them, we're able to assure ourselves that we're getting a weekly adjustment of their insulin as needed, and that way when they do see us at that 4-week mark, their sugars has been better controlled. Diabetes is one of those diseases where in a pregnancy you're going to always have to increase the amount of insulin, and it's always difficult to finally get the exact amount of insulin you need. So it's certainly a weekly adjustment that needs to be done, and that's the vital role our APPs play. They're able to communicate with the patients, and the patients know them, so they feel comfortable with going ahead and communicating with them. And once they have made contact with the patient once or twice, and the patient feels obligated. I mean, they feel the bond between them and the APPs, and they will be more apt to be sure that they're in touch with them and bringing their sugars in or sending their sugars in, so that they're able to have an adjustment. And that also then plays into them knowing that by doing these correction of their insulin as needed, that they're helping their baby.
Very good. And I also did talk to Lindsay, who is one of your APRNs, this morning, and she says on a weekly basis that they have contact with 30 patients in your clinic, and they also adjust insulin that way, and they also do classes for these patients and help them to better control their diabetes in that sense. Whereas if you were in the hospital and referred to a diabetic educator, it could take up to a few months to see those patients. And so,
well, pregnancy is just a difficult thing in that it's a very confined amount of time. When people have diabetes outside of pregnancy, it's a whole lifetime type of a problem. You don't think of being a 2-month wait time to get someone in to be that detrimental. But in pregnancy, you may you may have type 2 diabetes, so you have diabetes coming into pregnancy, or you are diagnosed with that in coming into the pregnancy, and you only have a very small amount of time to make a difference for both the mom and the baby, but mostly the baby, I would say. So by having the APPs and having them be able to contact a patient of mine, within a couple days of my seeing them myself, it makes it so much easier to get them on track and then to make a difference, because that's what we're talking about. It's not, they're going to have long-term issues with the diabetes, but in this setting, what we're attempting to do is to make a difference for the baby. And if you're waiting 2 months to be able to have an appointment to address that, then 2 months is quite a long time and can be detrimental to the baby and after birth as well.
All right. Well, thank you for taking the time to meet with me today, and thank you for what you do for our patients.